Hi, I'm Gabriella McCarty. Welcome to the GAP MASLD MASH Community Network. Thank you to GAP as well as Madrigal for sponsoring this program and making this possible. So I'm a nurse practitioner at North Shore Gastroenterology. This is a large private practice in the Cleveland, Ohio area. And I have been there for the past 26 years. I do general GI, IBD, and hepatology, so a bit of everything. And I do come across a lot of fatty liver patients, meaning I come across, they're not coming in to see me for fatty liver, they're coming in to see me for other reasons, but I'm finding it. Perhaps they have metabolic syndrome, so I want to look more into it. You know, we have FibroScan in our office, so I order that on a daily basis many times. Or I'm looking through old imaging and I'm finding that these patients do have fatty liver noted maybe on a scan 20 years ago. So they're not always happy to come in for something else and then be told that, you know, they have fatty liver and now they need a FibroScan, but I am telling you that in the long run, they will be very thankful to you. So we will get started, and today's focus is on MASLD pharmacotherapy. And that's me. And then use this QR code to record your attendance for this meeting. So I'll give you a second to get that scanned. And then don't forget to visit the GAP MASLD MASH Community Network to view Madrigal MASH disease state education, as well as Madrigal Resmetirom promotional program. And you can go ahead and scan that. All right, so we'll get started. So this slide contains a comprehensive three-pronged approach to managing patients with dysmetabolic liver disease. And on the left-hand side, you'll see that weight loss, this is the first area that we look at, and this remains a very effective intervention. And underneath weight loss, you'll see that this can be done via different ways. So of course, lifestyle, dietary changes, physical activity, lifestyle modifications, weight loss medications, bariatric surgery, and then the two highlighted drug classes here, the GLP-1 receptor agonists and GLP-1 GRP receptor agonists. These have the dual benefit of not only weight reduction, but also glycemic control. We always want to remember that in patients with advanced liver disease, we need to choose our medications appropriately. And then the second pillar there on the right-hand side, reducing cardiovascular risk. So this is really treating those comorbid conditions. So you want a control of blood sugar and blood pressure and cholesterol, and remembering that NAFL does not increase statin risk or drug-to-drug interaction. So a patient with fatty liver and even elevated liver enzymes do not need to be taken off of their hyperlipidemia medications or their cholesterol drugs. And then in the bottom middle there in the gold section, so we have treatments that now target NASH, so non-alcoholic steatohepatitis. Remember that nomenclature was changed to MASH, so in June of 2023. But now we have liver-directed therapies that work, how it sounds, directly on the liver by decreasing inflammation and reducing fibrosis. So we'll talk about vitamin E today. So that is not to be used in diabetics, but I'll mention that later. Pioglitazone as well as Resmetirom. Now, what do we tell our fatty liver patients right now? And I still call it fatty liver. It's just the easiest thing for everybody to understand. not always, MASLD or MASH, but so what we tell patients now, it doesn't change. We still want, with any of these therapies, we still want lifestyle and dietary modifications. So we tell patients to follow with their primary care for good blood pressure, cholesterol, and blood sugar control. I tell patients about the Mediterranean diet. We give them information on that. As far as weight loss, I tell patients that a good goal to keep in mind is a 10% weight loss of your total body weight over a 6-month time period. So not a huge amount, but even that 10% makes a difference. Liver's very good at regenerating itself if you do take care of it. I recommend complete alcohol avoidance to prohibit progression of fibrosis, as we know that alcohol makes that progression faster. And then exercise. I recommend 4 or 5 days a week of getting your heart rate up for 45 minutes. So not just a walk around the block. And if your patients are complaining of joint pains and they can't exercise, I tell them to get into a pool. And then, so that's basically what we tell patients now anyway, and what we should be telling patients in conjunction with any medical therapies, medication therapies that we may use. So let's get started with talking about these different types of therapies available. So the GLP-1 receptor agonists, I mean, we've come a long way with weight loss and metabolic disease for sure. So what happens in GLP-1, after we eat, our body naturally releases GLP-1, which is a hormone that does a few things. So number one, it boosts glucagon-dependent insulin secretion. It also lowers glucagon, which raises blood sugar. It delays gastric emptying, and it directly acts on the brain to make you feel full and reduce the amount you eat. So GLP-1 receptor agonists, they actually mimic the gut-derived incretin hormone. So it offers the same benefits in a longer lasting form. And also these GLP receptor agonists lower blood sugar and cause weight loss. So what is the role of these in hepatology and gastroenterology? I mean, up until now, and most of the time, we still see that endocrinologists are the ones that are prescribing these medications, but I predict that that will change over time. So there was a study done by Newsom. So the study showed that semaglutide, 2.4 milligrams once a week, improved liver inflammation, or MASH, and fibrosis or scarring without making either worse compared to placebo. So who should be considered are the best candidates for these GLP receptors antagonists are overweight MASLD patients with a higher priority to those with MASH or fibrosis, not for lean MASH. What about for GI providers? So in gastroenterology, up until now, most of the time we see patients in the office for symptoms or side effects from their GLP-1s. So I see a lot of patients with delayed gastric emptying symptoms, nausea, early satiety, and then constipation. So we're seeing most of these side effects, and I'm seeing patients that tell me they have to interrupt the dosing of their GLP-1s or stop it altogether because they can't tolerate the side effects. The other thing on the GI side is because of this delayed gastric emptying, this increases aspiration risk for sedation. So we had to change our preps to stay on there that patients on weight loss drugs need to hold these medications a week prior to any procedures because of this increased risk of during anesthesia, increased risk of aspiration and complications. We also had to put a sheet up in our rooms, in our exam rooms, because sometimes these drugs are not listed on their meds. You know, I've seen patients obtain these medications in unconventional ways. So it's just important that that is listed and that patients are telling you everything that they are on. What about vitamin E? So this is somewhat controversial. There's, you know, back and forth on this, but the dosage is 800 international units per day, and it's indicated for non-diabetic MASH patients without cirrhosis. The PIVENS trial was a landmark study that showed vitamin E improved liver histology in non-diabetic adults with NAFLD. And this happened in approximately 43% of patients. Now, limitations, not all patients respond, and we should not use them in diabetics or hypertensive patients. So it can interact with your diabetic medications. There's some increased risk of bleeding. There's some thoughts that maybe prostate cancer concerns. Also, vitamin E can lower blood pressure in mildly hypertensive patients. And if patients are already on antihypertensives, this could clinically result in problems. So, and it can also interact with hypertensive medications. And then there is maybe suggestive of increased risk of stroke. So a lot of things there to think about. As far as the guidelines, they differ. So in 2023, the ASLD guidelines suggest vitamin E may improve NASH in non-diabetic individuals. But then in 2024, the EASL guidelines do not recommend it as MASH therapy because of limited efficacy on fibrosis and potential risks. So what is the mechanism of action? So vitamin E is an antioxidant, and it decreases production of pro-inflammatory cytokines, inhibits oxidation of lipids in the cell membranes. It's a lot of different things. It can enhance insulin signaling, which reduces fat accumulation, and it can suppress the activation of these cells, perhaps reducing fibrosis. And then what about pioglitazone? So the dosage here is 30 to 45 milligrams a day, indicated for MASH patients with or without type 2 diabetes. And the PIVENS trial showed that there was no benefit of pioglitazone over placebo for the primary outcome of improvement of histologic features of MASH. However, significant benefits of pioglitazone were observed for some of the secondary outcomes of improvement of cardiovascular risk. As far as safety considerations, this medication can potentially cause some weight gain, edema, bone fractures, something to think about, especially in women, and a possible association of increased risk of bladder cancer. So any of these medications, you want to have a good full discussion with the patient and carefully monitor them. Now let's get to Resmetirom. So in March of 2024, Resmetirom received FDA approval in conjunction with diet and exercise for the treatment of adult patients with non-cirrhotic steatohepatitis or NASH with moderate to advanced fibrosis. So thinking about your F2 to 3 patients, it is a thyroid hormone receptor beta agonist, and it selectively binds to and activates the THR beta receptor in the liver. So let's talk about the thyroid and liver for a moment. So this THR beta receptor is highly expressed in the liver. It's not in the heart or the bones. We don't have to worry about increased bone fractures or changes in DEXA scans. But the thyroid and liver are closely connected, especially when it comes to how the body metabolizes fat. So thyroid gland produces hormones, T4, T3, and this affects many organs, including the liver. And these hormones bind to these receptors in the liver, THR beta, and they help boost fat burning or fatty acid oxidation. Also, they control genes like the CPT1A listed there in the liver that helps fat metabolism. And then it stimulates these enzymes, HMG, CoA reductase, and hepatic lipoprotein lipase, that increase cholesterol and lipid production. So a lot of interconjunction there between the liver and thyroid. Now, the mechanism of action in resmetirom, it improves lipid metabolism. It activates genes for fatty acid breakdown and enhances bile acid production, promoting cholesterol elimination. It also boosts mitochondrial health, and it increases formation of new mitochondria and reduces liver fat and inflammation, decreases hepatic fat accumulation, lowering inflammation, and it also has anti-fibrotic effects. So that scarring of the liver can improve. It inhibits hepatic stellate cells, reducing fibrosis and collagen buildup. Now let's look at the MAESTRO-NASH trial. This is actually an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. So these patients that were studied were adults and they had biopsy-proven fibrosis anywhere from 1 to 3. There were 966 patients that were randomly assigned in a 1-to-1-to-1 ratio to receive either once daily resmetirom 80, 100, or a placebo. And then they looked at 2 primary endpoints at week 52. One was resolution of NASH, including a reduction of the NAFLD activity score, or NAS, by 2 or greater points with no worsening of fibrosis, and also an improvement or reduction in fibrosis or scarring by at least 1 stage with no worsening of this NAS score. So what the score is a composite of histologic observations used for assessment of disease severity and NAFLD. They look at stenosis as well as lobular inflammation and hepatocyte ballooning. So it's basically taking the sum of all 3 of these. As far as safety, overall very well tolerated. Diarrhea and nausea were more frequent in the resmetirom patients than the placebo. And you can see placebo is the dark blue, resmetirom 80 milligrams is in the gold, and then resmetirom 100 milligrams is the gray or silver. So the diarrhea and nausea are transient symptoms they usually resolve within the first few weeks, and we just try to manage patients with either ginger ale, ginger supplements, antiemetics if needed, or Imodium, and usually they do very well. The incidence of serious adverse events was actually similar across the trial groups, including placebo. Now, as far as primary endpoints, we see significantly higher response in the Resdifra versus the placebo group in both NASH resolution with no worsening of fibrosis there on the left, and then fibrosis improvement, as you can see on the right-hand side. And what are some practical considerations for managing MASH with resmetirom? So this is ideal in patients with non-cirrhotic MASH and approved for adults. And these patients should have ideally stage F2 to 3 fibrosis. And it is only approved in conjunction with diet and exercise. So like I said previously, we should still be telling patients about these lifestyle and dietary modifications, even if we're putting them on drug therapy. And then do we need to worry about any drug-to-drug interactions with resmetirom? So medications to avoid with resmetirom are the strong C2 or the 2C8 or OP1B13 inhibitors, and these are listed on the left-hand side and include medications like gemfibrozil, cyclosporin, clarithromycin is one of them. And in the middle, we see the medications that have moderate CYP2C8 inhibitors. These are like clopidogrel. So if you do have patients on Plavix or clopidogrel, there is a lower resmetirom dose that's available. There's a 60 milligram dose for those patients. On the right-hand side, medications that are at risk of increased exposure due to resmetirom are those listed here, like montelukast, pioglitazone is listed on here. And then on the right lower hand side, depending on the metabolic pathway, sometimes your lipid lowering agents do need to be given at a lower dose. So perhaps if a patient is on 40 milligrams of simvastatin, you do need to lower that to 20 milligrams, and the same with rosuvastatin during the duration of resmetirom therapy. And then practical considerations when we're managing MASH with resmetirom. So duration of treatment and monitoring, there are no set guidelines yet. So there's ongoing evaluation with the MAESTRO-NASH trial. Likely we will need to restage fibrosis with non-invasive tests such as VCTE, PDFF, CAP, or ELF, and experts are currently working on when do we cut patients off therapy, how often do we test. Right now, I'll tell you what we do in our practice when we start resmetirom. We check liver enzymes every 3 months for that first year. We're reevaluating patients in the office in 3 months, checking LFTs at that time, making sure patients are not having side effects. At 12 months, we're redoing some type of non-invasive testing, most likely FibroScan. If patients are better, we continue the drug. If there was no change in their non-invasive tests, we consider continuing with additional maybe lifestyle dietary modifications. If the fibrosis was worsening, of course, we would stop the treatment. So as far as these non-invasive tests, so VCTE is vibration controlled transient elastography, which is FibroScan, which we are lucky to have that in our practice. So it's very easy to order and get patients done. They do need to fast for 3 hours. And this is basically an ultrasound technique that measures liver stiffness. And it gives us a couple scores. So how much fat is in the liver and if there's any fibrosis or scarring in the liver. The PDFF is proton density fat fraction. So it's a little bit more precise than ultrasound. It uses MRI technology. I think it's expensive and it's a little bit harder to obtain this test, at least in our area. The CAP score is part of the FibroScan, so that is the amount of steatosis, whereas if you heard the KPA score, kilopascals, that's the fibrosis or scarring. And then ELF testing, so enhanced liver fibrosis test. This is a blood test that's prognostic for advanced fibrosis. And it combines like 3 markers of fibrosis into a score, helping to predict progression. So there are still some questions that remain for managing MASH patients with resmetirom. So insurance coverage, of course, and there are multiple agents that are in clinical trials. So likely we will have more options in the future, which will probably further bring these drug costs down, making it easier for insurance to cover more patients. And then we still don't know like how often we need to do these non-invasive tests? How often do we need to monitor liver enzymes? And do we keep people on therapy for lifetime? And that's always a question we get with patients. And right now I just tell them we're going to look at things again in 1 year and then determine. And that is basically it. Does anybody have any questions, comments? Thank you for listening.